Thank you, Gauri Shankar sir and Ramesh Babu sir, previous speakers, because they have made it, my topic a little bit easier. They have made it very clear, like they have been telling about the importance of prompts and importance in education. Now I'm going to come to this AI in clinical practice, how we can use AI in our clinical practice. So outline of talk is, I'm going to speak about two tools. Already they have discussed about ChatGPT. I'm going to see about Perplexity AI and Open Evidence AI and a device which is a diabetic retinopathy screening device using AI. So coming to the Perplexity AI, just an introduction, it's a large language model based search engine. What the difference between the ChatGPT is, as you saw, whenever ChatGPT was analyzing, it didn't give about the source, whereas the Perplexity AI gives up details about the source and references and offers up-to-date responses. And it is very useful, especially in the point of care of decision making. So I'll simply tell you an example. This happened last week actually. This is a 46-year-old female, known diabetic, presented with an acute onset of this rash for just 3 days. It was non-itchy and non-pruritic, and this was the complaint she was having in both the lower limbs. So actually what happened is, I called my dermatology friend, but he was not available. So what it is, I uploaded here. We can see here. So I just uploaded the image and asked the Perplexity AI about what are the possible diagnosis. No, just I am giving an example. See, what is this? See, I have given identify the skin condition for a female patient who presented with acute onset since 3 days. And the most important thing is, you see that if it analyzes these sources that is given here, almost it's analyzing 20 sources which are relevant to this picture, because that is not seen in ChatGPT. And you see that it summarizes that these are all the lesions which are present, acute bilateral and mildly itchy lesion, and what are the possible differential diagnosis it has made very clearly. You can see that the most differential diagnosis, acute leukocytoclastic vasculitis or HSP, but even though HSP it is not common, and has told about thrombocytopenic purpura and what are the recommendations, diagnosis, how you put forward. For example, you do a CBC and all these things. So in summary, it has given us the most important diagnosis is leukocytoclastic vasculitis and HSP. And most importantly, it has given that even if it is HSP, you should have the triad of renal involvement and arthritis should be there, which is not seen in the patient. Now, I have done the certain investigations and I uploaded that. So normal CBC, actually I admitted the patient had a normal CBC, normal RFT, LFT, and her ANA was negative, C-ANCA and P-ANCA, everything was negative, and there was no thrombocytopenia. And it analyzes again. We can see that assessing the next steps in the patient management, and it has come to a conclusion clearly that, see, it has given the findings like all ANA, CNA is negative, and next step is, with this result, the likelihood of systemic vasculitis is ruled out, and most important cause can be cutaneous small vessel vasculitis. And what are the recommended steps next? Like symptomatic management is enough, and when to escalate further, whenever the patient lesions become ulcerative, or when the patient develop new lesion, then skin biopsy can be confirmed, can be done. And it has put it as a very detailed summary table. So this is what happened actually to the patient. I admitted and all the investigations were negative, gave symptomatic treatment, and the patient lesion almost resolved. And now, little bit much more, because I'm lazier, I have put that, can you make the course in the hospital for this patient, the discharge summary. It has made it very easily. I think it has made it well in hospital course, and what is this thing? Almost everything. What are the investigation and management, and what advice, progress, how the lesion progress, and discharge plan, what has to be given. Everything is given very clearly. So I think everybody can get astonished with this. See, actually, if we have because this is based on, if you use this same thing in ChatGPT, it may not be this much effective, because this had been not feeded. As they said, in large language model, you have to repeatedly feed it, because this Perplexity has been made with repeated sources regarding with all this thing, and it analyzes based on these journals, and then it gives the report. So now, next is the open evidence. The open evidence is just advanced to the Perplexity. What it does is, it's a platform that critically appraises clinical evidence using AI. It presents the data in a very structured, clinical-friendly format and transparency with evidence source tagging. I think this is the open evidence AI. We can see that, you can see the reference with this. It has the leading medical information platform on Mayo Clinic platform, NEJM and JAMA. So what are the advantages? You get references from these journals. So the authenticity of the information will be very good in this when you use this platform. And most importantly, open evidence has a number of advantages. Like you can ask a very tough question, like what strategies you use to optimize heart failure management with reduced ejection fraction, or you can even ask the AI to make MCQ questions based on the topic, or you can ask double check, or you can ask about any drug interactions, you can ask about treatment options, and you can ask about the recent guidelines. It gives in a very clear way, and you can ask it to do a research topic, and you can ask it to make for a mock exam. These are all the options which are available, and you can ask about the drug side effects, and you can even ask it to construct a workup plan. For example, if you have a hypocalcemia or hypercalciuria, what next to be done, and we can do a number of things, ask about what are the treatment alternatives and everything. Now, actually, I'll give an example for this open evidence, what I did. For example, one of the commonest doubt which you have, what about the antiplatelet therapy which we use, whether So I ask this question, what are the evidence and current guidelines about starting a prophylactic antiplatelet therapy in a diabetic patient for primary prevention? So if you see that, it analyzes all the articles. I think that sign is seen there. So and now it has given a practice guidelines, like what the ADS advises. It can be considered as a primary prevention strategy only for those who are at increased cardiovascular risk after a comprehensive discussion with the benefits. And it also says that the net benefit is most likely in adults aged more than 50 years with diabetes, and at least one additional major risk factor should be there, like family history or ASCVD or hypertension or kidney disease should be there. And decision to initiate aspirin should be made after discussing about the bleeding risks. And if you see that, it has analyzed all the articles, and it will give you the detail in the summary in a very nutshell point at the end. So in summary, the current consensus in a diabetic patient, antiplatelet therapy is not recommended for all diabetic patients with primary prevention. So this is what, whenever you have a clinical doubt, you can ask. And most importantly, you can see the references. Almost all the references are given, and when you click on the references, that will direct you to the original article. For example, I clicked on this, then it is directed to the PubMed article. So now you should know the authenticity of the information which is given in this. Unlike in ChatGPT, where you may not know the reference, but here you may know the reference and you see whether this information is correct or not. So now after finishing the two tools, now coming to the device, the diabetic retinopathy screening. This is the world's first smartphone-enabled non-mediatic camera with on-the-edge artificial intelligence. Actually, what is it? It's a device, handheld device, where you can screen the patient retina even without dilating it. And it provides a high quality imaging and very portable, and it's designed for handheld use. And it has most important thing is it has an offline integrated AI algorithm. I'll show you. Actually, this is how you screen the patient eye with this. It has an inbuilt camera by a phone, iPhone, by which it takes the photo of the fundus, and then it analyzes. You can see here. See, even though there are changes in this fundus, we can see that the AI marks those changes, like where are the retinopathy changes are there. And then it gives you whether the patient has a clinically significant macular edema or a moderate NPDR, which is called as the referable diabetic retinopathy. So when you are sitting in your diabetic clinic, and you can't send every patient to screen for diabetic retinopathy, you can use this handheld device and you can screen it, and then it will generate a report immediately within 10 seconds with lesions are all marked. So it will be very easy for you to explain to the patient that these are all the area where you have lesions in the eye. And these are all the various images which are captured on the fundus on phone. We can see various types of retinopathy and severe NPDR, CSME, everything. So this is one of the report which I used in my clinic. You can see that initially it marks the lesion. Actually, I'm not sure whether you are able to see there. In the right side, it marks the patient has significant signs of diabetic retinopathy screen, and it marks where areas it has been there. So now the validation is actually all trials and clinical endpoints included minimum mandated sensitivity and specificity. Almost it has 85% sensitivity and 82.5% specificity. It has been validated in various community centers, diabetes centers, in hospital setting, and the performance is comparable when run on desktop camera images. So I think that is the fundus camera. I asked them to bring it. It's very handheld device which we can use it easily. Almost it's very